Okay, good morning and good evenings. How are you? I am Dr. P.Y. Cho and my colleague, Dr. Junior too. We too will moderate the webinar today too. Welcome to ICC webinar. Dr. Raymond Tse is an associate professor at the University of Washington and the director of the brachial plexus program at the Seattle Children's Hospital. Professor Tse's clinical focus is in pediatric plastic surgery with special expertise in cleft lip and palate, ear reconstruction, brachial plexus palsy, and hand surgery. Dr. Tse's research follows his clinical interest. It ranges from care for measurement of deformities, deficit, and the surgical result to the family's experience through surgery and the decision-making process. Dr. Tse is heavily dedicated to clinical care and research. However, he also devoted time teaching medical and dental students, residents, and fellows. Academically, we already read numerous very famous papers from PRS be conducted by Professor Tse's teams. And by the way, Dr. Tse is coming from the same institute with the Professor Richard Harper, Seattle Children's. So he is the co-host of the coming year's ISCFS in Seattle. Today, we are so honored to have Professor Raymond Tse with us to present the topic, the unilateral cleft lip nasal deformity, insights based upon three-dimensional image analysis and their clinical implication. Also, two experienced craniofacial surgeons are invited to the panel. Dr. Gung Seo from Busan National University Hospital, Korea, and Dr. Tinchen Lu from Chang Memorial Hospital, Taiwan. So I think in the very beginning, I would like to invite Professor Tse to say hello to all of us. Hi, Raymond, please.
Good morning. It's a true honor to be here. I've wanted to visit in Taiwan for a long time. Chang Center would be a place where I think I would learn from and enjoy to visit one day. My apologies for doing this lecture as a talk. It's the Thanksgiving weekend here, and we're up in our condo. It's a small one, and the kids are sleeping. So I figured this way we could play the video. It'll be a little bit quieter, and then when we get to the discussions, hopefully they're not too lively. Then I can make a little bit more noise.
No problem. So let's play the video first. Okay.
The unilateral cleft lip nasal deformity, insights based upon 3D image analysis and their clinical implications. I have no disclosures other than that I'd love to see you in Seattle this coming September. The textbooks tell us that the cleft side alar base is displaced laterally. They tell us that in order to correct the deformity, we need to advance it medially. They tell us that the non-cleft side is normal and the ideal reference for symmetry. And they tell us that the nasal dorsum deviates towards the side of the cleft. Finally, they tell us that the retropositioning of the alar base can only be addressed by filling the bony gap at the time of alveolar bone grafting. To quote an old colleague of ours, it turns out that they're all wrong. While putting together objective data for our approach to primary rhinoplasty, we noticed that it was actually the non-cleft alar base that was displaced lateral and that it shifted medially with repair. Meanwhile, on the cleft side, the cleft alar base is retruded and moves anteriorly to achieve balance with little to no change in its medial to lateral position. So we examined 3D images of 100 patients and age-matched controls, normalizing those images to standard midline and rotation so that X, Y, and Z axes could be defined. What's the alar base displacement pre-op? If we take these landmarks and plot them on this figure with non-cleft and cleft sides and the X and Y axes, on average, this is what we get. If we take the non-cleft alar base and transpose it to the other side, it turns out that the cleft alar base is medial relative to the non-cleft side. That means that it's the non-cleft side that's actually displaced laterally. If we superimpose the normal controls, again, it's the non-cleft side that's abnormally displaced. Now what happens with surgery? This is pre-op, and here's post-op. And strangely, it's the non-cleft side that seems to be changing and approximates that of normal controls. And so if we're seeing all of these non-cleft side changes, what's happening on the operative cleft side? If we look at the Z-axis, as expected, the cleft alar base is retruded. With surgery, it moves forward to approximate that of normal controls. How do things progress over the course of the next few years? Here's pre-op, here's post-op, and at 5 years of age, prior to alveolar bone grafting, the symmetry persists. Along the Z-axis, this is pre-op, post-op, and at 5 years of age, prior to alveolar bone grafting, the symmetry persists. So paradigm 1, neither side of the cleft is normal, and it's actually the non-cleft alar base that's displaced laterally. This used to be my teaching slide for the residents. I would tell them that the alar base needs to move inwards, upwards, and forwards, and this is totally wrong. And this is now my new teaching slide. The columella and the non-cleft alar base need to shift towards midline, whereas the cleft alar base needs to advance anteriorly with no significant change in its medial to lateral position. So for those who do rotation advancement repairs, it may actually be more accurate to describe this as a medial rotation and advancement of the medial segment with lateral anterior advancement. Because if we don't get this right, you have this situation where you could do anything you want with the nasal tip, but because the foundation is crooked, the nose is going to continue to collapse. Paradigm 3. Stable anterior correction of the alar base can be achieved prior to alveolar bone grafting, regardless of the cleft type or the size of the bony defect. Seeing that we got a few things wrong, we decided to take a step back and see what we could figure out and get right. One of the fundamental principles of plastic surgery is to have a clear understanding of the deformity and the ideal normal. And so we went back to look at the unrepaired deformity and build a 3D data-driven model to explain it all. We propose that the anteronasal spine and caudal septum drive the deformity. This is consistent with Latham's finding in fetuses and our observations that the caudal septum is almost always immediately behind the anteronasal spine. So if we took all of the images from the study and ordered them according to how far the subnasale deviated from the midline, we found that there was an orderly progression from incomplete clefts in green, complete clefts with seminar band or soft tissue band in blue, and complete cleft in red. If we plot the other landmarks, using regression analysis, we found that with each 1 millimeter deviation of subnasal from midline, the cleft alar base remains relatively stationary, whereas the non-cleft alar base gets pushed out with the columella. This is what the model looks like in an animated form. It morphs from the least severe to the most severe, with everything in between. You can see that as the cleft becomes more severe, the non-cleft side shifts away from the midline, while the cleft side becomes more retruded. The orthogonal vectors of displacement result in collapse of the cleft side nasal dome. If we take that model and now look at specific anthropometric dimensions, this is what we find. These are the changes in dimension for each 1 millimeter displacement of subnasale from midline. In green are dimensions that are growing, and in red are dimensions that are shrinking. Focusing on the nose, as expected, the cleft base width widens, the columella tilts, and the nostril collapses. But what hasn't been clearly described is that the non-cleft nostril narrows. This makes sense because uncoupled growth of the premaxilla centered at the base of the columella is driving the nose upward and outward and pushes against the non-cleft alar base, squishing that sill and making it more and more constricted. You can see that here in these photographs. On the left is a child with an incomplete cleft, and on the right is a child with a complete cleft. And you can see that as the cleft widens, the non-cleft nasal sill becomes constricted. As a result of that constriction, the alar crural ring gets pinched, and the tip defining point on the non-cleft side rises and becomes more prominent or bulbous. And so there are non-cleft side changes, and you can perhaps call them deformities because of the opposing changes to the cleft side. In terms of the lip, as the lip height along the cleft shrinks, so do the dimensions adjacent to the cleft, and this is all as expected. The more severe the cleft, the more the hypoplasia along the edges of the cleft. What hasn't been described is that the non-cleft side actually grows. You can see that in green, so that the filtral height on the non-cleft side ends up being taller the more severe the cleft is. So if you've ever felt that less severe clefts are so much easier and more severe clefts are so much harder to balance, it's because it's true. There are opposing changes on each side. Again, you could see it here in the photographs. On the right side is a child with a complete cleft lip and palate, and the filtral height is elongated on that side. And so the non-cleft side is deformed, even though it may not be as distracting to our perceptions. It's incorrect to talk about the non-cleft side being normal or healthy, because the non-cleft side is abnormal and deformed, but less distracting. And so I'll get back to this theme of opposing changes and the importance of recognizing the non-cleft side alterations in relation to the cleft side alterations. In the meantime, I'm going to finish talking about our model. In addition to traditional anthropometric analysis, we used computer vision techniques that assess shapes and curves in an objective manner to further analyze our model. For each 1 millimeter displacement of subnasally from midline, we found that there were quantifiable losses in nasal tip symmetry, alar cheek definition, the angle between the cheek and the nose on one side versus the other, as well as of dorsal deviation with a 1.8 degree swing toward the non-cleft side for each 1 millimeter displacement of subnasally from midline, in the exact opposite direction to that illustrated in important textbooks, Hogan's tilted triangle, Huffman's work, McCarthy's text, and most diagrams that you might find on Google. So if we're confused about the deformity, we're not going to be very good at fixing it. While the implications and changes in clinical practice is going to be up to all of us to shape and to determine, these are the things that I think we can learn from it. The first is that I think that we can simplify the goals of surgery to these. We need to untwist the nose by centralizing the columella, advancing the cleft alar base anteriorly, and then balancing the alar base positions. I use David Fisher's approach to cleft lip repair, and I know that he spoke at the symposium earlier this year, so I'm honored to be following. The repair is a good one, but the many landmarks can be intimidating. So I've modified the numbering system, and each landmark is an anatomic landmark that new cleft surgeons should learn and experienced cleft surgeons should be able to recognize. Each of those landmarks helps to define the border of an anatomic subunit so that together these define the markings and the pattern of repair that will land along the borders of anatomic subunits. A lot of the detail is contained in these articles, and I have given a 1-hour webinar on how to put together the landmarks and the design, which I won't go through today because that will take a little bit too much time. Ultimately, if you look at these landmarks, there are non-cleft side and cleft side landmarks. They're asymmetric in configuration at rest, but they're symmetric when the nasal elements are balanced. And so these form the framework for developing repair that balances nasolabial form. For example, in this case, you can see that with repair, the non-cleft nostril sill widens, the upper lip subunit changes shape, and the philtral height on the non-cleft side diminishes, whilst the columella is centralized and brought to the midline of the face. This changing border of the anatomic subunit on the non-cleft side is important to keep in mind because we want to match that when we're done surgery, but it really is only revealed through surgery. And so using and leveraging all of the anatomic subunit landmarks when we design our repair can help to anticipate this. Again, creating that matching anatomic subunit is inherent to the Fisher repair, but it's not so with the rotation advancement unless you use something like the Onizuka modification, and so I would encourage that if that's the repair that you use. The Fisher repair, I think, can produce favorable nasolabial form. In green is a child with microform cleft lip. In blue are the kids with incompletes, as well as incomplete with a mini microform on the contralateral side. In orange are the kids with complete cleft lip with Simonart band or soft tissue band. In red, there's one kid with preoperative NAM and all the others with complete clefts with no NAM. And in the bottom is a child with a complete cleft with midline deficiency, the so-called Bindroid variant. And so I think the repair can be applied nicely across all cleft types because it considers the non-cleft and the cleft sides in the design as an inherent part of it. While we can focus on cleft lip repair and the surface markings, what I think all of us will recognize is that beyond those markings and beyond that preoperative plan, there's a lot that goes on. And so we wrote this follow-up paper describing our approach to correcting the nose. Now, most people think of primary rhinoplasty entailing dissection of the nasal tip to upright the lower lateral cartilages. Recurrent deformity is common, and most patients eventually require secondary revision. So we developed an alternate form of rhinoplasty that focuses on correcting the foundation in order to upright the nose. It starts with the identification of points of closure along the nasal sill that produce the nose that you want. These are landmarks according to Fisher's approach. Along columella, there's the subnasale as well as the two peaks of the philtral columns along the nasolabial crease. On either side are the subulare and the alar insertion points. There's a crease that begins at the junction of the nose and the lip and continues into the nose along the medial foot plates. There are other creases that extend from the base of the ala and run into the nose. And where these two creases intersect on the non-cleft side, we define this point X. Using those creases and the previously identified landmarks, we can then identify corresponding landmarks on the medial side of the cleft as well as on the lateral side of the cleft that, when brought together, produce the nose that we want. On submental view, you can see how when you bring those 2 points together, it produces the nasal form that's desired. And when you let go of the lip and let the nose slump back down, all of the components spread back out, so the configuration of the landmarks is asymmetric, but we still know of those 2 points that we need to bring together that, when brought together, will produce the form that we eventually want. With that, I think it's useful to centralize the columella because that's the structural form underneath the surface that is aberrant and deviated over. And so with the medial lip incisions, we can gain access to the intranasal spine, identify the caudal septum, and centralize it to the midline of the face. I use a subperiosteal approach on both sides of the septum, and with release of the periosteum on the non-cleft side, the septum can be centralized to the midline of the face. It's secured with a suture, and with all the periosteum and perichondrium intact, it can be a very robust structure that can be sutured nicely into place. Through an upper buccal sulcus incision, it's a supraperiosteal dissection on the anterior surface of the maxilla, which transitions to a subperiosteal approach along the piriform aperture. That subperiosteal incision allows access to the lateral nasal wall on the lateral side of the cleft, pictured right here. Inside the nose, on the above images, we're seeing the lateral side of the nose. The incision runs along the cleft margin and then ascends to the base of the inferior turbinate in green, so that the entirety of the lateral nasal wall can be advanced en bloc with the cleft alar base, so that we can close the nasal floor and stabilize everything into the new anterior position. Here's the periosteum as it's closed from posterior to anterior. I use a Tajima suture to secure the lower lateral cartilage over top of the upper lateral cartilage. And I use alar transfixion sutures that lateralize the vestibular skin within the nostril so that the airway is open, and that accentuate the alar crease so that it can be more defined. What I think is really critical to the repair is the muscle dissection and the muscle inset. And so on the medial side, I will delaminate the muscle from the base of the columella so that it produces a dead space underneath the columella. On the lateral side, the muscle dissection is even more aggressive. It's delaminated and then it's released from bone high up in the vestibule so that it produces an empty triangle that's devoid of any muscle within that triangle. Here's the diagram form of that muscle dissection. On the left is prior to dissection, and on the upper right is following release. There is a dead space underneath the columella on the medial side, and on the lateral side we produced an empty triangle that has no muscle lateral to the nasal ala. We then bring the muscle from the lateral side and inset that into the dead space underneath the columella. And while most of us would think that we're advancing the lateral muscle medially, if you actually watch what's going on, or at least when I'm doing this, when I look at what's going on, I can actually see that the columellar base starts to shift medially as I tie my knot down so that it starts to centralize along the midline of the face. Meanwhile, on the lateral side, that muscle is just moving anteriorly to support the base of the ala in its new position after we've advanced it and released it. And so in many ways, the movements are advancement on the medial side and rotation on the lateral side so that we can support the alar base into its anterior position. So you can see the progressive changes in these three images as we move along from pre-op to correction of the septum and the sidewall and the nasal floor. With no nasal tip dissection, pretty significant nasal tip changes are occurring. And in the bottom, the final muscle and skin inset produces the final change. On submental view, again, pre-op, following correction of the septum, reconstruction of the sidewall, and creation of the nasal floor, there is pretty significant changes in the nasal morphology. And then on the right, the final muscle and skin inset produces the final change, again with no nasal tip dissection. So by building foundation, we can produce profound changes in nasal morphology. Does NAM help? We looked at this question in kids with complete cleft lip and palate, looking at their outcomes at 5 years of age prior to alveolar bone grafting. In these examples, in the above is a child who had NAM, and the below a child who had no NAM. The initial presentation was fairly similar. There were some changes, obviously, that were visible immediately pre-op, and at 5 years of age, there are some differences that can be visualized and can be noticed, but the difference is relatively small. And so it's kind of a gray answer. It does make a difference, but it's not a massive difference. Can nasal tip dissection be incorporated into foundation-based primary rhinoplasty? Absolutely. But if you do, it's important to make sure that the foundation is set right, because if you don't, in these examples, the nasal tip has been dissected, but because the foundation isn't balanced, the nose will always look crooked. In some ways, it's kind of like this. If you're just dissecting the tip and leaving the foundation unleveled, you're always going to have a crooked roof. So going back to these paradigms, 1, neither side of the nose is normal, and both sides are deformed. 2, the non-cleft alar base is laterally displaced. 3, we can correct the alar base position prior to alveolar bone grafting. And 4, the nasal dorsum deviates away from the cleft as opposed to what's been depicted in most of our diagrams. Why is all of this important? Well, it's our fundamental principle. We need to understand the deformity and the ideal normal, because if we don't, we're going to continue to falter in our abilities to correct things. The unilateral cleft lip nasal deformity continues to be an unsolved problem, and we want to improve our outcomes, and we want to avoid iatrogenic deformity. The other reason why I think this is important is that it helps us with our basic understanding of the condition and provides us with a model so that we can understand why things are the way they are. Our model complements and links current concepts. Stenstrom stretched out the lower lateral cartilage and explained that that's why the nose was deformed. Latham identified uncoupled growth of the premaxilla as a key feature of the embryologic pathogenesis. Hogan proposed the idea of a tilted tripod, and Fisher proposed the idea of these arch forms that define the nose and how they can be stretched out and deformed. Cutting identified changes up to the nasal bones, and Kane identified asymmetries extending all the way up to the cranial base. The data from our studies can be used to better guide our models. For example, Hogan proposed the tilted tripod, and Fisher identified these nasal arch forms. But we don't have a clear data-driven idea of how the components of these change. Until now. And above in red is the lateral deviation of subnasally from midline. Underneath that are the components of the tripod in green. And as opposed to what has been depicted in the tilted tripod, the tripod legs change in a different manner. And so we've clarified that. And then below in blue are the nasal arch forms that define the nose. And again, we have a more accurate and clear definition of how the bases of those arch forms actually move and change through the severity of presentation. In addition to clarifying the tilted tripod and the nasal arch forms and how they change with increasing severity, we also introduced other concepts with our model. Going back to this diagram, we found that with each millimeter displacement of subnasally from midline, the endocanthial distance increased, as did the interchelion distance. So we can't explain everything based on unhinged premaxillary growth. There seems to be an ascending split of the facial skeleton that ascends all the way up to the cranial base. And it may be that loss of the horizontal maxillary buttress allows the mid-face and upper face to start to splay in this kind of splitting manner. While Tessier's diagram is typically thought to only apply to atypical facial clefts, it's probably very applicable to the ordinary clefts that we see. What I find really interesting with all these paradigms and misperceptions is why we have all of them. And it may be that it's kind of like an optical illusion. In this diagram, the square labeled A and the square labeled B are the exact same shades of gray. They don't look it, but they are. When you place a reference, you can see now that what I say is true. And so all of these paradigms and misperceptions may be due to some of the context that we have. Our review articles, our textbooks, even our board exams tell us one thing. And if we focus in on the nose, they may look like they're true, but if we step back and look at the bigger picture with references and guides, we can see that the truth is actually quite different. So regardless of whatever field you work in, I think this is the bigger message. It's important to challenge dogma with objective data. This is a quote from me from several years ago when we were trying to sort out this business of the cleft and non-cleft sides. Ezgi, who was our computer science engineer at the time, I said, "You've mislabeled the landmarks. I'm a cleft surgeon and I know what I'm talking about. I'm a surgeon, you're a computer science engineer. How can you understand what we're doing?" Turns out I was wrong. Now's our chance to get things right. And I hope you can all walk away with these pieces that can help you to improve the care that you provide. Uncoupled premaxillary growth drives the deformity. The caudal septum follows the intranasal spine. The deviation then drives the twist deformity. The non-cleft ala and columella deviate away from midline. Meanwhile, the dorsum gets dragged along, and the cleft alar base is left posteriorly. Together, these result in cleft side collapse. With these changes along the cleft, there are opposing changes. The non-cleft nostril gets squished, the non-cleft nasal sill gets distorted, and the non-cleft philtral height grows and bows. For those of you who are very visual, hopefully you just walk away with at least these diagrams. You can see with the uncoupled premaxillary growth, subnasal is driven away from midline, up and forward and away. And with correction, we need to centralize that columella. We need to balance the alar bases, and with that, we can correct the arch forms that define the nose. Thanks again for the invitation to meet with you. It's an honor to be here. I'd love to visit Chang one day. Hopefully what I've shown you will help you improve the care that you provide, and I look forward to learning from you how I can improve the care that I provide.
Thank you, Professor Tse, for the amazing lecture. And I think I can speak for all of us when I say that I think all the participants learned a lot from that lecture, and there's a lot of things that we can take away from this presentation. Now, before we head over to our panelists, I'd like to invite all the participants to write down any questions that you might have for Professor Tse in our chat box, and we'll have him to answer these questions during the Q&A session. So now I'd like to invite Dr. Tse. Hi, Dr. Tse.
Hello, can you hear me?
Yes, we can hear you perfectly.
Yeah, sorry, something is wrong with my PC, so I connected with my mobile phone. Sorry for the not a good connection. Yeah. Hello. Okay. So can I comment?
Yes, please.
Yes,
So
Yeah. Yeah, Professor Raymond, it was really a nice presentation. It was so impressive. Let me ask one question, because sorry, it's a little bit late in Korean, so yeah, sorry. According to your presentation, you routinely treat the septum. I mean, reposition the septum to the midline. But some surgeons still have a little bit afraid that that kind of the procedure, I mean, touching the septum can produce some kind of gross retardation of the nose in the long-term follow-up. So how do you think about that? And could you give me some comment of the long-term effect of the septoplasty for the cleft patient?
Yeah, absolutely. I think a lot of what we do, we don't know the long-term outcome of. Septal repositioning has been performed for a long time. The data so far looks like it doesn't change facial growth or nasal growth, but it's only really a thin amount of data that we have, I think. I think in the last few decades, more and more surgeons have been starting to reposition the septum. And I think we'll have to see, does it actually affect growth or not? I don't know. For now, it's what I learned to do. It seems like it produces a nice change. My kids are 15 years of age or so. I haven't seen it, or at least noticed that that's an issue. But, it's hard to sort out. There are kids with more complete clefts who do have some maxillary undergrowth. And we'll have that at baseline. Is it more than if we didn't dissect out the septal, if we didn't dissect out this caudal septum? Hard to know. So I think the answer is to be determined. Don't know. And I think I'll be the first to admit that, I think it's a learning process for all of us. We'll have to see.
Thank you.
Thank you. For our next panelist, I'd like to invite Professor Liu.
Hi, Dr. Professor Raymond. I think I have attended your lecture in ACPA for at least twice to listen to your lecture about fissures. So actually, I think I already heard about this lecture before, and I feel it's very interesting, and I totally agree with you. So I only have two questions. So the first is, I also do the septal correction for all the kids, but I didn't do any sutures on the septums. So do you think it's necessary to do the sutures to fix the septums?
Yeah, I think there's two ways to centralize the caudal septum. One way is to release the perichondrium on the non-cleft side and then bring the septum to midline. I think if you do that and you've closed your nasal floor on the cleft side, the septum naturally centralizes, and by the time you're done, it's right in the midline of the face. And in that case, if you want to put a stitch there just in case to make yourself feel better, you can. If you don't want to put a stitch there, I think you can leave it and it probably stays there. But I have adopted a slightly different way of centralizing the septum. Again, I don't know if it's better, worse, or the same, but I will leave the perichondrium intact on the non-cleft side, and then I'll release the periosteum on the non-cleft side. So I'll leave the perichondrium intact. So then now I've got a virgin plane on that septum if I need to do a septorhinoplasty years and years and years later. The advantage of that, I think, is that undissected plane. The disadvantage is that the cartilage doesn't straighten as easily on its own. And that's where I think the suture is important, because that is what helps hold it in the midline and keeps it straight. And so with the subperiosteal approach, I think you do need a stitch. If you go subperichondrial, I think you could probably just close the nasal floor and it's just fine. I'm a little bit of a worrier, or I get anxious. And so even if I do a subperichondrial approach, I'll still put a stitch in when I'm done, just so I feel better that it's not going to move around.
Okay.
But you could probably do it without a stitch, as you do.
Thank you. So my second question is, our patient, they are all Asian patients. So you know that the Asian patient's nose is much worse than the Caucasian nose. So do you do any difference from for the Asian kids from the Caucasian kids?
I think the nose is different in that the cartilages aren't as large and robust. And so I do the same for Asians, in that Asians, I mean, the nasal features are kind of similarly not as large and robust. The nose is a little bit flatter. It's a little bit, not as projected. And so I feel like if I do the same thing, I get a centralized, a balanced, symmetric result. And it's not as projecting as a Caucasian kid, for example, but it's ethnically appropriate for them. I wouldn't want to have an ethnically Asian child look like a ethnically Caucasian in terms of their nose, because it's not going to match the rest of their facial features. So I really focus on balancing elements, and if I've got them balanced, then I feel at least it's ethnically appropriate or genetically appropriate for somebody's phenotype.
Okay, thank you very much.
Thank you, Professor Liu. And next, I actually like to invite Professor Fayyad for a few comments. Professor Fayyad, are you available?
Yes. Hello. Thank you very much,
Hi,
Raymond,
Gulam.
thank you very much, Raymond, for enlightening us. I still remember your comments during the Edinburgh conference, where you highlighted that the non-cleft side is also not in the right place. So that's why I have requested you to write a chapter in my coming new book, because many of us, they always feel that it is only the non-cleft side which is at fault. However, because of the muscle contraction on the normal side, the not only the cleft side has gone away, even the non-cleft side has been shifted more laterally. So I appreciate your insight, and I'm sure that as more and more friends from across the globe learn your thoughts, we will be better equipped to address to the deformities even on the non-cleft side. So I really congratulate you to letting us know your thoughts, and I'm sure we will be more than happy to learn from your techniques, and we can rightly address the issues when we see your thoughts.
Fayaz, thank you. I'll put that chapter together for the
Thank you.
textbook, and glad to do that. And I think it's an interesting phenomenon. I have to say, when this data came out, it changed the way I looked at things, and I think a lot of people will centralize the columella. And I think a lot of surgeons, when they tie those knots with those muscles, I bet they'll see that non-cleft side shifting over, and that septum, the columella shifting over. It opened my eyes, and I think I'd encourage everybody to watch as you tie that stitch, what's moving.
And maybe I can suggest you can develop a small algorithm to guide the friends, like in incomplete cleft, like in microform cleft, like in cleft 0, or in unilateral, or even in bilateral cleft. Maybe you can develop an algorithm to provide the guidelines.
Yeah. I have an algorithm, and I guess with the most recent Nelgen textbook, I helped write the chapter with David Fisher. We had that algorithm in there, but everybody told me to take it out because there was so much already in David Fisher's markings that they thought, "Oh, this is way too much stuff. This is a lot of material." But you're right. I think it's an important piece. What do you do when for an incomplete cleft or complete cleft? When do you release the upper sulcus? When do you move things? When do you get more extensive on your dissection, or when do you minimize it? I guess it's like there's a story of Goldilocks. You don't want too much, you don't want too little, you want just right. And I think that's the same for every cleft. Is the more you do isn't necessarily better. It's trying to get things just right for each child, each cleft.
Thank you. So kind.
Thank you, Professor Fayyad. And last but not least, I also like to invite Professor Lowe for a few comments.
Yes. Hello, Raymond. It's nice to hear your talk, and I think your method is interesting. I think it's like David Fisher's technique is similar, but it's quite useful and helpful for the young surgeon to learn how to design and how to execute the operation. And I think you also point out the importance of the non-cleft side, which is not normal. And when we repair the cleft, we need to also pay attention to the non-cleft side and bring that back to the midline. So I think this is an important message to all the people in the audience, because I think most of the people here are also actually doing the credit repair. That's message is quite important. Thank you again, and nice to see you.
Yeah, nice to see you. I feel very much like I learned from you because David Fisher was my mentor, and he learned from well, he trained in Gung and took a lot back and incorporated what he does. So in some ways, I feel like I'm a product of the Chang Center, or at least what I do.
Thank you.
Okay, thank you, Professor Low. Next, I think we'll move on to our Q&A session. I think we have around 4 or 5 questions, so we'll quickly go through them and try to get through every single question if we're able to. So our first question is from Dr. Russell, and he wants to ask Professor, do you expect any growth disturbance after performing primary septoplasty? And then he also like to ask you about your long-term results.
Yeah, you know, as I mentioned, there can be facial growth disturbance. There can be nasal growth disturbance. I don't know. You know, the preliminary data that's out there suggests that it's not that impactful, but we'll learn over time whether it is or how much it is. And I have to say, I don't know that we can say that something causes growth disturbance or doesn't. I think pretty much everything that we do as surgeons can produce some degree of growth disturbance. It's just a matter of how much and how we accept what that impact might be relative to the way we do everything else. And ultimately, you're right. At the end of the day, the long-term outcome is the key. In terms of my long-term outcome, it's about 15 years now. As far as kids with unilateral clefts in their noses go, I've done probably 1 or 2 revisions over the last 15 years. Obviously, it's going to be more with time. I expect that I'll be doing septorhinoplasties for children, mostly for their nasal airways, but to produce the final adjustment of their nose. But so far, it's really just been primary repair and then waiting for septorhinoplasty without any revisions in between. So seems like it's working okay.
And we have a few doctors asking, would it be helpful to anchor more laterally to the upper border of the orbicularis muscle for the non-cleft side?
If I'm kind of listening to that correctly, you know, I guess the question is it worthwhile insetting the non-cleft side to the lateral cleft side?
No, I don't think that's what they're asking. I think they're asking whether it would be helpful to anchor the non-cleft side a little bit more laterally, and then set it onto the upper border of the orbicularis muscle.
Non-cleft side. Yeah, I don't know. I mean, I think ultimately, you've got to do what produces the best balance possible. Currently, I empty the muscle out of the base of the columella, and when I inset the lateral cleft side muscle into that, that drags this columella over to the midline. And sometimes when I'm insetting that stitch, I'll actually inset that stitch a little bit beyond the columella and onto the non-cleft side. So now the muscle is inset onto the non-cleft side. Sometimes if I inset that, it's too much. I'll see the lip thin out on the cleft side, and then I'll just revise that. But if I see a little pull on the non-cleft side from the cleft side lateral muscle, then that's something that I want to see. Every now and then, I'll do something that's also a little bit strange in that if the non-cleft side alar base relative to the medial canthus still looks displaced laterally, I will sometimes put an alar cinch stitch on the non-cleft side, securing it to the premaxilla, just to bring it in a little bit. When you put a cinch stitch on both sides, it drags the cleft alar base medially, which is not what you want, because otherwise everything's going to be shifted over. And so that's why sometimes I'll use a unilateral non-cleft side alar cinch stitch if it seems like it needs to come in a little bit more. But again, I'm learning, and I think the interesting part of all of this information is that I think it opens the door for all of us to really re-examine what we do, and see if there's a better way of doing what we do. I hope that answers the question.
And Dr. Olusanya wants to ask what type of suture and what size do you use for the septal repositioning?
Yeah, I use a 3.0 PDS, and I secure it to the premaxilla. The premaxilla periosteum doesn't hold a stitch very well, so I'll actually put it through the periosteum, through the gingiva, and then come out the mouth, and then loop back from the mouth back into the dissected area. And that way there's a secure stitch to hold the septum where I want it.
And Dr. Rith wants to ask if you regularly perform the Tajima incision.
I don't make a Tajima incision. I referred the suture that I place as a Tajima suture. So there's no incision. It just is a matter of elevating the lower lateral cartilage, putting it over top of the upper lateral cartilage, and then putting a mattress stitch to hold it there. It's a mucosal pexi stitch. And so without any dissection, without any incisions, it may not produce as much of a change long-term as if you made an incision. But again, I prefer to preserve the tissues if I can, if I do need to do a later septorhinoplasty, so it's a bit easier. And at least that's just my choice in terms of my approach. Again, the effect is a bit smaller than if you made an incision, but maybe it's okay, and it allows for easier surgery later if we need it.
And then I think Professor Honda follow up this question by asking, so do you make any attempt to move the cleft side alar base medially? So I guess the Tajima suturing is your method of trying to attempt to move it medially, if I'm...
No, the Tajima stitch is what I use on the cleft side. It's
Okay.
inside the nostril, and it's repositioning the lower lateral relative to the upper lateral cartilage to produce the scroll area just on the cleft side. On the non-cleft side, I don't do anything in the nose, other than I want to see that alar base move medially a little bit when I'm insetting the muscle stitches. And you can also see that movement a little bit with the skin inset. So I think it's really the muscle and the skin that's pulling the non-cleft alar base medially. I don't do anything else otherwise.
And we have a question from Dr. Miranthi asking, when you're doing the muscle manipulation, are there any special suturing techniques that you use, and whether you divide the muscles before you manipulate them?
Yeah, that's a good question. I typically will just use a direct, simple stitch to approximate the muscles. The reason I do that rather than a vertical mattress or horizontal mattress that some people will do is that I know that the orbicularis muscle is made of multiple layers. There's a superficial layer, there's a deep layer. They each do something. One's a constrictor, one's a dilator. And I'd like those muscles to line up as much as possible together. I know that some people will dissect and separate those layers. I don't feel like I can do that effectively because muscles are pretty thin, they're pretty small, and they're pretty delicate. And so my thought is if I just bring the muscle as a block, a straight approximation, hopefully I can get the superficial line with the superficial, the deep line with the deep. When it comes to preparing the muscle for repair, I dissect a little bit more aggressively on the lateral side. On the medial side, I don't dissect very aggressively at all. And sometimes I barely dissect the muscle because I want to keep that philtral dimple and keep that depression. And I worry that if I delaminate, I might lose that. On the upper side, or the more cranial part of the muscle, I'll dissect more aggressively on both sides. But as you go more caudally, you have this very delicate shape of the pars marginalis. And it's this J-shaped muscle that you can see when you section the lip. And I want that muscle to come together so that the J part is aligned. If it's malaligned one way or another, then the muscle is going to be malaligned and the lip shape is going to be malaligned. And so that J shape, I think, really helps with the poutiness of the lip. And when I prepare the muscle, I barely dissect the muscle from the vermilion, from the skin, from the mucosa, and I use careful stitches to try to get that J shape all aligned so that we have a nice pout to the lip.
And our last question is actually from Dr. Sakya, and the question is, while doing septoplasty, do you sometimes need to incise the septal cartilage to straighten it?
I don't. Again, I worry about nasal growth disturbance. So I try to straighten the septum as much as I can just by bringing it to midline. And I don't do more than that, just out of concern that if I'm too aggressive, there may be some long-term downsides to it.
Sorry, and I have one last question actually from myself. I want to ask you whether you use microscopes for your operation, or do you prefer to use loops?
I just use loops for this operation. In fact, my senior partner, Richard Hopper, when he does lip repairs, he emphasizes that he doesn't use loops. He wants to be able to see everything. He wants to see the whole face. He wants to see the balance of everything. And so he doesn't use loops. I feel like I need loops to be accurate with what I do. I just use 2.5 loops. But I think, going more magnified than that, I think you can be more accurate with alignment of everything. But at the same time, if you do that, you do need to kind of be able to step back and look at the bigger picture and see the whole face. Because again, I think if you really just focus on this little area here, you may miss the overall balance, and things may not be as straight as you think they are. And so when I drape faces, I used to drape just this area. With kind of all this data that I presented, I now drape everything so I can see the whole face, I can see the ears, I can see everything. That way I'm producing as much facial harmony, facial balance, and I'm considering everything when I'm putting things together.
Okay, thank you so much. I think that's it for all the Q&A questions. So I'll hand it back to Dr. Cho.
Yes, thank you, Junior. Okay, thank you. We appreciate Raymond's your comprehensive talk. Would you like to give us all the participants more information about the ISCFS, the coming Congress in Seattle? Yeah, okay. Please.
Yeah, I mean, I think my senior partner, Richard Hopper, is organizing it. It's going to be in Seattle in September. It's a really great time of year to be in Seattle. Generally, temperatures are mild, but it's pleasant. The days are long. And I think Seattle is a great place to visit. I would love to see you all there. I'd love to meet you in person if it's possible. And I'd encourage everybody to look it up. And if there's an opportunity, it'd be great to see there.
Okay. So how will be the weather then?
Weather generally in September is good.
Okay.
I think in the it's the first week of September, so it's just the end of the school break, and weather's still
break.
good. And living in Seattle, I never leave the area in the summer. It's just the perfect place to be. It's not too hot. It's not too cold.
Wow.
It's all the other months around the summer that I think sometimes you want to get out of Seattle. But in the summer, no, this is where I am.
That's great. Okay, thank you. I hope I can see all of you in Seattle in the coming year. So I hope all the participants can show and turn on your screen and give me your smile. And I have to take the group photo together with Dr. Raymond Tse, and to thank her very comprehensive and using a very dedicated analysis, the method to calculate and to finalize what is the true structure of the unilateral cleft lip and palate. So I will count to 3 and please show me your smile. 1, 2, cheese. If okay, could you give me a thumb or give me a heart? Thank you very much. 1, 2, cheese. And I turn to the next page. Okay, wait for me. Yep. Again, I will count to 3. 1, 2, cheese. Thank you. Okay, thanks again. I know it's the very early morning, 7 a.m. in Seattle time. So Professor Tse is getting up very early and to catch up with me and the junior around 1.5 hours ago. And thanks to Dr. Raymond Tse again for your very great talk with all of us. Hope to seeing you in person. Okay, and I have to promote our next coming speech. That is will be presented by Professor Nivaldo Alonso from Brazil to give us a talk how to do and address the cleft orthodontic surgery. Okay, 2 weeks later. Okay, good morning and good evening. Looking forward to see you again in the coming presentation time, in the coming webinar. Thank you, Professor Raymond. Thank you all. Bye-bye.
Best
you,
wishes,
everybody.
Raymond.
And
Bye-bye.
Best wishes.
Thank you,
Have a
Professor
good time.
Fayaz. Have
Oh,
a good
thank you.
day.
Thank
you,
you,
Sol.
so kind.
Thank you, Sol. Thank you, Professor Handa. Thank you, Tin Chen. Yeah. Thank you, Raymond. Have a good day.
Thank you.
Have a nice
I'll
day.
tell you one fun little fact. My 2 kids, they're 5 and 6.5.
Okay.
Their favorite restaurant to go to is Din Tai Fung.
Oh,
They ask me every day. I want to go to Din Tai Fung. So one day I'd like to come to Taiwan and go to the real Din Tai Fung.
No problem.
Oh,
You
good.
have to
definitely,
come
definitely.
the most authentic one in Taipei.
Yeah.
Yeah, just let me know when you are coming. See you.
Okay, sounds good.
Thank
Take
you.
care.
Bye
Thank
bye.
you
Yeah,
again.
bye-bye. Thank you. Thank you, everyone. Okay, bye-bye, bye-bye.
Bye bye.
Thank you, Junior.
Thank you, Junior. Bye-bye.
Bye-bye.
Bye,
Thank you,
Sol.
Sol. Thank you very much. It's very late in Korea.
Yeah, yeah. You should get some sleep.
Go to bed. Go to bed.
Okay.
Have
My
a good
baby
night.
are waiting me. So
Okay.
Bye-bye.
Bye-bye.
Keep in touch.
Yeah. Good. Keep in touch. Thank you, Professor Fayaz.
Thank you, Professor.
Okay.
Okay, bye bye.
Okay. Bye. See you.